So my name is Tina Sindher. I'm one of the allergists at the Shannon Parker Center, and I wanted to review the topic of EoE or eosinophilic esophagitis today. And I've kept them kind of brief, and it's really more kind of going through the process and what it is and kind of how it links up with oral immunotherapy. And then I'm happy to kind of take some questions later on. And I, again, apologize. I don't know what's happening with my Wi-Fi today, so I'm logged in. But if I get disconnected, I will be back again. Okay. So next slide, please. Okay, so EoE or eosinophilic esophagitis, it's a chronic inflammatory condition where it's characterized by esophageal dysfunction as well as eosinophil predominant inflammation in the esophagus. It was first characterized as a distinct disorder in the 1990s. Next slide, please. So over the past 2 decades, as we have seen with other atopic conditions such as food allergy, asthma, eczema, we're actually seeing the same trend in EoE as well. The incidence and prevalence has been increasing. The current prevalence is 1 in 2,000. There is a known male predominance where males are affected by EoE at a rate the ratio being 3.1 compared to females, and it's more commonly affects allergic or atopic individuals and adults more than children. Next slide, please. And then I also wanted to talk a little bit about food allergy and the kind of the immune spectrum when it comes to food allergy. One end of the spectrum is IgE-mediated allergy, where your body has specific IgE antibodies. It recognizes the protein in a specific allergen, and then when you're exposed to that allergen, it identifies the IgE, and you have an allergic reaction triggered by mast cells and basophils. And then on the other end of the spectrum is more delayed type conditions that are not IgE mediated. And when it comes to EoE, we see more of a mixed type presentation where there is this connection and association with IgE mediated conditions, but the IgE testing or eliminating just the food allergens alone sometimes is not enough to address EoE. So there is a mixed picture there. Next slide, please. In terms of the natural history of EoE, so if it is left unchecked and uncontrolled and the inflammation is just allowed to progress, it will over time lead to fibrosis and remodeling of the esophageal wall. And that is kind of the long-term issues we want to prevent. We want to prevent strictures and narrowing. And over time, from childhood to adulthood, we can see these take place, which is why EoE is so important to kind of work closely with your providers with and kind of keeping an eye on with routine endoscopies to see how it's progressing or whether it's controlled or not. Next slide. And then what we have noticed is that EoE presents differently in adults versus children. In children, and I currently do EoE clinic with GI and nutrition, and I've also seen EoE in my adult patients. And what's interesting is in pediatric patients, we elicit symptoms of EoE by asking questions like, are they experiencing heartburn? Are they having, kind of constant nausea, vomiting? Are they gaining weight? Okay, because we do see failure to thrive in little babies who have EoE. They have feeding difficulties, and we ask questions like, are you burping a lot? Are you bringing up food? Are you, questions like that. Whereas in teenagers and adults, the most common presentation ends up being difficulty swallowing or food impactions. Like the first time they get diagnosed with EoE is when they were eating food or taking medication or a pill, and it gets stuck in their throat and they end up in the ER, and that, ends up with a scope, and that's how EoE gets identified in them. The difference that we see in pediatric versus adult, we don't completely understand the pathogenesis behind that. What we don't know is it just presenting differently because of the immune process in kids versus adults, or is it that these patients had subclinical EoE for a long term and they're presenting clinically in adulthood as the condition evolves over time? Next slide, please. Some of the risk factors that we see associated with EoE is that it is diagnosed more in urban areas. There seems to be higher prevalence in areas that are in cold and dry climates. We've also found early life exposures that can contribute to dysbiosis linked to EoE. And this kind of ties in with that atopic conditions as well. So they found, early use of antibiotics or C-sections, formula feeding, other items that can kind of affect the microbiome can also increase the risk of EoE down the line. Also, one of the things that we are seeing more in as oral immunotherapy becomes common is there is also a risk associated with oral immunotherapy or sublingual immunotherapy. Next slide, please. So atopy, and this is where, when they're also allergic to other, they have other allergies. So the majority of our EoE patients, and it can be as high as 80%, have what we call an atopic phenotype, meaning they may have eczema, they may have asthma, they may have oral allergy syndrome, seasonal allergies, and food allergies. They tend to have just elevated IgE to foods and aeroallergens. And some studies have found that EoE diagnosis can actually vary by season, with the highest rates being diagnosed during the summer or fall when the overall environmental pollen load is very high. And in adults, studies have found that sometimes airway allergy or environmental allergy precedes the development of EoE. Next slide. So the diagnostic criteria. So EoE initially is kind of considered if a patient comes in and they, are endorsing difficulty swallowing or taking, small bites or chewing for a long time or drinking lots of fluids while they're eating to kind of get the food down, or if they're presenting with kind of, just chronic abdominal pain, more located in the upper areas, reflux, nausea, vomiting, that seems kind of out of characteristic for them. So these symptoms may kind of trigger the suspicion of eosinophilic esophagitis, but they're really, the gold standard of trying to diagnose it is through an endoscopy. And if the biopsy shows that there is 15 or more eosinophils per high power field, that then meets the criteria for EoE. Other things we also have to keep in mind is that some other conditions may also trigger eosinophilia in organs, and you can have it, peripherally, just high eosinophils or through medications. So you kind of have to be on the lookout that is the eosinophils explained by some other conditions. But if they're having the symptoms and the endoscopy shows eosinophilia in the biopsy, then we usually think of EoE first. Next slide. So when we do an endoscopy, in addition to doing a biopsy, the GI provider also looks at kind of other findings in your esophagus, such as linear furrows or mucosal rings. They look for the lumen size. So from long-term inflammation, the opening can get narrowed and makes it harder to swallow food. Strictures, there might be ulcerations, and just overall thickening of the muscle there. So all of these things are signs that the gastroenterologist is looking at when they do an endoscopy. And this can kind of trigger, next steps and management considerations. Next slide. So in terms of therapy, this is where there is no kind of best option for anyone. It really ends up being this shared decision making. And part of the reason we do this multidisciplinary EoE clinic with GI, nutrition, and allergy is that there is no one best option for any patient. It really depends on their symptoms, how their esophagus looks in the scope, and kind of what is feasible for them and that family, whether it's child or adult, what is feasible for them to do. Because the best treatment is really what is doable and manageable and feasible for the family. So the main options that we explore include, treatment with a proton pump inhibitor, or PPI. These include medications like omeprazole or lansoprazole. The other medication that we use, quite commonly are topical steroids. So medications that we routinely use for asthma, such as Flovent, we might ask a patient to kind of puff it in the back of their throat, or do swallowed budesonide, where you mix it in with Splenda or thick it and create a slurry so that it coats the esophagus and reduces the inflammation. And then elimination diet is another one that we explore quite routinely, especially in our food allergic individuals. And this will come up a little more when we talk about OIT a few slides down. So with elimination diets, we explore kind of different levels of, I guess you could say, intensity. So there's the 2-food elimination diet where we would avoid milk and wheat. They tend to be the most common allergens for EoE. So if we're going to try it, we sometimes try with those two. If that's not enough, we can add egg and soy to the mix as well. And that's the 4-food elimination diet. And then the 6-food would be kind of eliminating the top allergens associated with food allergy as well. So this would include milk, wheat, egg, soy, peanut, tree nut, and we also throw in their shellfish and fish depending on the family's diet. And then based on whichever treatment we employ, and sometimes it's a combination approach, whatever we try, we have to keep that regimen going for at least 8 weeks and sometimes longer to see if it has an impact on the results of the scope. And then based on the scope, let's say a family is trying 6-food elimination plus, let's say, a PPI. We do the scope and the esophagus looks amazing. Then we have this conversation about, okay, what do you want? Do you want to reintroduce a food that would increase your quality of life, or do you want to avoid the PPI and see if the elimination diet is going well, to see how that would play out? So there's a lot of conversation, a lot of touch points, and just kind of having discussions about what will work best. And there's no right answer for anyone. So it may be that we try one thing, it doesn't work, and then we may have to go back to the drawing board and try another strategy, or add on more therapy, or remove some along the way. Okay, next slide, please. One of the questions that comes up a lot is allergy testing. And one strategy that used to be employed in the past is we would do either patch testing or food allergy testing, and use the testing results as a indicator of what foods to avoid. And numerous studies have actually explored this, and the newest guidelines actually do not recommend allergy testing directed food elimination anymore. So that no longer is how we are choosing our foods. It ends up being 2-food, 4-food, 6-food. And then if that's not enough, we may add on more foods based on the child's diet or allergy history or OIT history. But we don't start off with allergy testing as a determinator of what foods to avoid. That that being said, I do want to add in that I see a lot of food allergic patients in my EoE clinic as well. So if there is a food that they are sensitized to, or if they have previously tested positive to, and it is a food that they're eliminating, then I worry that as they try to reintroduce that food once their EoE is under control, that they may have a reaction. So we do food allergy testing as a way to gauge our risks of an allergic reaction, like an IgE-mediated allergic reaction, meaning they may have difficulty breathing or swelling or hives all over. And let's say they do test positive, so that reintroduction would then be done in the clinic setting as an oral food challenge just to make sure they don't react. But typically, I don't use the testing to direct which foods to avoid. Next slide, please. So now to kind of talk about EoE and oral immunotherapy. So in a systematic review where they did a meta-analysis of numerous studies, they actually found the rate of new onset EoE in patients undergoing oral immunotherapy to be about 2.7%. And in these patients, and these were new onset EoE, once they discontinued the oral immunotherapy, the EoE resolved and it was no longer an issue. And the reason this ends up being something we talk about in all our OIT studies now and in the consent form, where EoE is considered to be a risk for if you're on oral immunotherapy. Next slide, please. But what's important for us to keep in mind, and this we've seen from our POISED trial, which was a study that our center was involved in, involving 120 patients. In these patients, 20 patients were randomized to also receive endoscopies throughout their trial, and serial biopsies were obtained at different time points. And out of these 20 patients, 5 patients were found to have increased eosinophilia, and 3 of them had it at baseline even before they started oral immunotherapy. They did not have any clinical symptoms. They were not, all the symptoms that we talked about, which is difficulty swallowing or inflammation, reflux, vomiting, food impaction. They didn't have any of those symptoms, but they did have elevated eosinophils at baseline. And then while on OIT, 4 patients ended up having increase in eosinophilia. 1 patient out of 120 patients actually had true EoE, who then discontinued OIT, but the other patients, their eosinophilia actually went down. So what we found is that some patients may have transient elevations in eosinophils that goes away on its own, especially if it's not associated with clinical symptoms. Next slide, please. And there are a few investigational drugs that are currently being explored for the treatment of EoE. Omalizumab or Xolair, which is routinely used in asthma, food allergy, has also been explored in EoE without much luck. It has not been very beneficial. Other biologics that they've looked at as anti-TNF alpha agents or other IL-5 blockers such as meparazole and reslizumab, which are approved for asthma, did show some benefit, but it hasn't been, a resounding effect that makes us, we're hopeful, but it's not that exciting yet. And there are ongoing studies with anti-IL-13s. But the reason I wanted to kind of bold the dupilumab is that we currently were involved in a study with dupilumab for the treatment of EoE, and their initial data looked very promising. And it is currently FDA approved for eczema. So for my EoE patients who've kind of failed steroid therapy or PPI therapy and have tried elimination diets and still not getting the level of control we would like, if they also have eczema, And I've been trying to get them on the dupilumab as well, but it has been sometimes, depending on insurance and whatnot, it's not been an easy road, but we're hoping that once this drug becomes FDA approved, it'll be much easier to include and treat patients with. Next slide. And then I just wanted to review kind of the future things, future directions for EoE diagnosis and what's being explored in the works. There was a pilot study done with the milk patch to look at EoE patients who also had milk allergy, and they did find some success with the patch. There's a new diagnostic avenue being explored. It's called a cytosponge, where it's a mesh attached to a string that's swallowed in a capsule, and it dissolves in the stomach. And then the capsule dissolves, so the sponge expands, and you pull it out, and you collect some mucosa along the way, and you can test the tissue that's collected, and the histologic evaluation can kind of point out inflammation associated with EoE, and it accurately diagnosed EoE 83% of the time. And then the other test that our team is also exploring as part of an oral immunotherapy study is the esophageal string test, where an absorbent string is, one end of it is taped to the cheek, and the other end is attached to a capsule, which is swallowed. And again, the capsule dissolves, and then when you pull it out, the inner part of the capsule is able to kind of pull up cells with it. And when it's analyzed, it can actually help differentiate between inactive EoE patients versus active EoE patients. And it was also able to give us differentiate between patients who had just really bad reflux and normal patients. So these are, all ways that we can kind of minimize the risk and the invasive nature of endoscopies and help guide management of oral immunotherapy, especially if we suspect EoE may be of concern. And so numerous things being explored. There are lots of unanswered questions, but we're hoping that by talking about it more and learning about it more, researching more, we'll have more and more answers down the line. So that is the end of this presentation. So I'm happy to kind of go over any questions, and if we run out of time, which we will, there's like a couple minutes left, I'm happy to respond back via email as well.
Hi, Tina. Thank you so much. And thank you everybody here on the line that came to our seminar. We really appreciate your time. I do have a question. I'm gonna say answer live. On a CBC blood test, what is eosinophils? If it is higher than range, what could that signify?
Yes, so we do look at, so eosinophils are part of, when we collect CBCs or complete blood counts with differentiation, we will find eosinophils as one of those markers in there. As allergists and immunologists, we look at the absolute eosinophil count, and in our allergic patients, most of them, majority of them have high eosinophils. And that's called peripheral eosinophilia, as in it's in your blood. That does not help us with the management of EoE, because we really need to see how much of the eosinophils are part of the esophagus, not so much in the blood. But I will say that if the peripheral eosinophil counts are very, very high, with the absolute count being greater than 1,500 on numerous occasions, that will trigger a further immunological workup. So, so short answer is we do not use that value to help manage EoE. However, if it's consistently elevated, that definitely warrants a further workup.
Thank you, Tina. I have another question here. I don't know if it's, I think it is a little specific. So do you see the questions tab by any
Yes,
chance?
I do. Yep.
It's from Kathy. So I don't know if you want to answer that live or if you want me to gather address.
So if it's okay, I can read that out loud. So diagnosed with eosinophilic gastroenteritis following OIT, which was stopped after being on meparazole for a year plus. How long is too long for meparazole? That's an excellent question. So we have some of our patients on high dose PPIs for several years. I would say that as part of our clinic, we routinely test for vitamin D levels and bone density. We just kind of keep an eye on overall nutrition because we do worry about long-term side effects. And another thing that we've come across is some of our kiddos on long-term PPIs can also get oral esophageal thrush. So another thing to keep in mind. So every person's different. So if your child is tolerating the PPI, that's great. However, in what we always try to do is if someone's doing well and their symptoms are under control, we will try to slowly kind of take the PPI off and see how he tolerates it. So I would recommend kind of touching base again with the GI provider, because anytime someone's symptoms are really well controlled and they're on medications, it's worth considering, what happens if you take the medication off? Is the EoE under control now that OIT is no longer part of the picture? I hope that answered the question, but if there's additional follow-up from that, we can, Tina, you can maybe connect me and I can answer via email.
Yes, I can. I want to swift through the cues and see which one
the next
answer. And I know some people, it's the 1 o'clock time, so I know some people have to leave, but this is being recorded, so I'll post it and send out a link. But you can continue, Tina, if you have the time.
Yeah, no, I can stay on. Another person mentioned that they have a 14-year-old son who's on maintenance OIT for a peanut allergy for 2 years, diagnosed with EoE, which resolved when OIT was removed. Considering trying OIT in the future, symptomatic with EoE with reflux. This is another great question that we don't have an absolute answer for, just because every person is so different. A lot of newer protocols are exploring kind of a low dose strategy for OIT to see if that minimizes EoE. And now with our esophageal string test being incorporated into some of our OIT trials, we may be able to answer some of these questions, as in, how the inflammation is evolving. Are there specific characteristics of the inflammation that makes it easier for some folks to continue with the OIT versus others? If this EoE was triggered by the OIT alone and not because they were going to develop EoE, regardless of OIT, then the OIT may bring it back, but it can also be dose dependent. So what I would recommend would be, if they are doing well, and their primary allergist and GI doctor is okay with trialing OIT alone, again, it may be worth going low and going slow. So trial of very, very low doses to see, and taking your time, going slow, seeing if that triggers any of the symptoms. If it does, then I would just stop right away. The other thing to consider is that dupilumab, which we're also exploring for food allergy, has been shown to be efficacious in EoE as well. So that may be in a few years, that may be an option too for our EoE kids who may be on OIT, because not only will it help the EoE, it can also help the OIT process. Do we know yet? Oh, that brings me to the next question, is whether Dupixent will prevent EoE if used in conjunction with OIT. That's an excellent question. Another one that we don't have evidence for yet because it has not been explored in that way. But I do see a use for it, where I think if someone is using Dupixent for OIT or eczema, it would be interesting to see if that long-term kind of minimizes or helps manage the EoE more. As we learn more about Dupixent in the realm of EoE and food allergies, these questions will definitely be answered. Is there a pre-screening for EoE risk before starting food allergy OIT? Yes. So before starting OIT, we do ask questions about signs and symptoms that may be suspicious for EoE. Again, if this has not been officially diagnosed, it may be harder to pick up. But things like, are they at baseline having a lot of abdominal pain or problems with reflux? Has it been evaluated? Have they been scoped? So if there are GI concerns even before starting OIT, it is worth evaluating. The other thing I wanted to mention also is that GI symptoms tend to be the most common when doing OIT. In our POISE trial with 120 patients, 90 of the 120 participants had GI symptoms. That's 75%, but not all, clearly not all of them. 1 out of 120 patients developed EoE. So GI symptoms do present quite a bit. So we will talk about EoE a lot. We will ask about EoE a lot, but most patients do not develop it. Let me see. My son is 15, and the last few months he's had a couple of incidents of difficulty swallowing and pain. I would get that explored, especially in the setting of food and seasonal allergies. What we find is that sometimes kids are very adept at kind of just managing their symptoms by making changes in their lifestyle. For instance, if they have difficulty swallowing, they might take smaller bites or chew longer or use a lot of fluids while they're eating or use a lot of ketchup or other kinds of additives that makes swallowing easier. So they're able to make lifestyle changes without actually complaining or noticing that they're having difficulty swallowing. So if at any point that does come up and if teenage male has allergies, those are all in the high risk category or for EoE. So I definitely would recommend reaching out to your primary doctor about that. Swallowed steroids can make EoE worse. Are there side effects of OIT? So swallowed steroids are one of the treatment options for EoE. So it should make the EoE better. But EoE is considered a side effect of OIT. So it is always something we want to discuss when undergoing OIT and having that in the back of our minds. Currently, the main way to diagnose it is through endoscopies, but with these newer strategies such as the esophageal string test, it makes it easier to be able to maybe assess esophageal health in the clinic setting, but that's still several years out before we're able to utilize it prime time in our clinics. But at least in our studies, we're trying to incorporate it, and hopefully we'll have some more information on that. If OIT causes EoE, how long usually takes for EoE to resolve after OIT is discontinued? That varies from person to person. Some kids may actually report feeling better within weeks, but by definition, to really prove that it's better, we have to do an endoscopy, because what we find is clinical symptoms don't always correlate with actual esophageal flare or inflammation. So really at least 8 weeks to really answer that question of, is the EoE better after stopping OIT?
Hey, Tina, did you want to narrow it down to a couple more questions, or?
Sure.
Up to you.
I have I see one more question. I see, so our son has been diagnosed with EoE and has eliminated with these foods with no improvement. Never told. We measure smaller. That's an excellent question. So it is not, all we can really tell is whether basically 15 and more, you have EoE. If the delta is important, for instance, let's say before it was 100 and now it's 20, that is definitely an improvement, but little bits of variations here and there is not enough to give us the scale of the problem. So it's not like we categorize it as mild, moderate, or severe EoE unless you have kind of strictures, but really it's a matter of, are eosinophils present or are they not? So if the EoE is still present, I would recommend kind of having another conversation with the GI doctor to seeing, well, two things. One is, was this diet really strict? Like, because if there are even a few cheat days in there, that can cause the inflammation to return, the eosinophils to return. But if it was very strict and, the best effort was done, then maybe considering addition of PPIs or steroids to help manage the symptoms. Yes, and the last question, can the string test be used as an alternative to periodic EGDs? So that is our hope. It's not an absolute replacement for EGDs. So I do think that we will still need occasional EGDs, but what it will help us do is these kind of interim questions of, making a few adjustments and without having to wait the full 8 weeks and then undergoing anesthesia and doing the EGD, we're hoping the string test can give us more real-time, immediate answers, at least in the sense of, is this the trending of the inflammation and which direction it's headed? So we are hoping that it will hopefully be a replacement for the EGD, at least in between scopes, and will minimize the need for frequent scopes.
All right, Tina, I think we can end it here if you're okay with that. Thank you for attending and giving us your time and attention. Any last words, Tina?
No, thank you everyone so much for coming. And I'm sorry my Wi-Fi was being tricky and we started a few minutes later than planned, but please don't hesitate to reach out via email and I will try to get as many questions answered as possible.
All right, thank you. And
Thank you.
there was an anonymous question. If you want to message me privately, I can grab your email and get your questions answered if it wasn't answered in this webinar. Thank you, everyone.
Thank you so much. Bye.